Once again, if you guys want to chime in your answers on the chat room, feel free to do that. A little bit more fun for you probably. Okay, so we've got a shave biopsy in this case, and this was a neoplastic process. Chat screen a little bit smaller. Maybe I can't. Oh, same size. Okay. Anyway, neoplastic process, and we sort of are compromised because we can't evaluate breadth, symmetry, circumscription, and a lot of those various things. So when we look at it, obviously, we think it's benign or malignant. A little difficult to tell at first. What kind of differentiation is it exhibiting? And if we go to higher magnification, you're going to see that it's kind of got a spindle cell morphology to it. And we've been through the spindle cell differential before. So obviously, we think of the three classic ones: neural, muscle, fibrohistiocytic. But then there are some others that come up on occasion. So sometimes you need to think outside the box. The endothelial cells can sometimes be spindle in shape. Squamous cells can be spindle in shape. Fat cells, we talked about spindle cell lipoma last week, that can be spindle in shape. And then sometimes melanocytes. Again, there's 8 different sort of morphologies of melanocytes, and one of them is spindle. So spindle and epithelioid cell nevus, for example, Spitz's nevus. So that's certainly another one. So as we go to higher magnification, we see that these cells, again, are arranged in these fascicles. Some of them are a little bit hyperchromatic. There might even possibly be a mitotic figure or two in here. So when we don't have the ability to use architecture, we have to rely on secondary features for whether it's benign or malignant. We look at cytology, look at things like whether it's diffuse, replacing adnexal structures, whether there's any maturation, whether there's mitotic figures. So those are all things that we might need to look at here. So we see something like this. Tough to tell the differentiation. We've got a differential. Is it malignant? It's very possible. It's pretty diffuse. It goes to the base and the sides. And some of these cells are a little bit atypical. And then if we're not sure of the differentiation, well, we look in other locations. So let's look at the blood vessels. Are there any features there that look unusual, or any endothelial cells floating freely in the lumen? And I'm not even, some of these are blood vessels, but some of them are just spaces like here and here. And there's none of that. There's no large endothelial cells, so it's probably not a vascular neoplasm. Could be, but that'd be less likely. It's in the dermis. So again, it could be maybe a fibrohistiocytic process. But then we always look at the epidermis too. What if there was a contiguity with the epidermis? Good, somebody said melanocytic. And so yes, melanocytic neoplasia. And then you can see that these melanocytes, there's one that's hyperchromatic here. It's a little bit larger here. There's some pagetoid spread of melanocytes over this area here. So maybe this might be a variant of a melanoma. If you look down here, you see these cells are pretty atypical down in here as well, even though there's not a lot of mitotic figures. So if it's melanoma and it's a spindle morphology to the melanoma, and it's got features of lentigo-maligno overlying it, does anybody have any idea what kind of variant on the theme of melanoma that it might be? So when you see this area here, that ought to at least give you some clue as to what that is. And you guys have probably heard of it. Yes, desmoplastic malignant melanoma. And desmos is the Greek word for tendon. And so it means that the cells are spindle and they kind of look like a tendon a little bit in there. So that's why it's called desmoplastic melanoma. And the reason that might have been shaved, will give the clinician the benefit of the doubt, but they probably didn't think it was a melanoma. They probably thought it was something else. So if you saw somebody like this in your clinic, I doubt that melanoma would be the first thing on your mind. You probably would think of maybe possibly an unusual epithelial neoplasm, or maybe atypical fibroxanthoma. So you might not do a punch or a deep, well, we don't like punches of melanomas anyway, unless you're going to punch out a very large part of it. But you probably wouldn't do a deep incisional biopsy, for example, or an excisional biopsy like you get taught to to do when you're thinking it's a melanoma clinically, because these don't look like melanomas. They can often look like scars. They can look like fibromas. They can look like non-specific lesions. It's pretty rare that these get sent into us as rule out desmoplastic melanomas. So clinicians don't think of it. They often take a shaved biopsy. Maybe it doesn't show the atypical melanocytic proliferation overlying it, which you can see maybe 30 to 40% of the time where you don't see that. And maybe it just looks like a sort of a bland spindle cell lesion. And maybe it looks more like a neurofibroma, something like that. So you can easily miss this diagnosis clinically and histologically, and then it ends up in a medical legal situation. So you have to be careful of that scenario here. So somebody said, how do you tell from a spindle cell melanoma? Basically, spindle cell melanoma is probably one sort of subtype of this type of melanoma. So that's really sort of, there's no real reason to distinguish that. These generally tend sometimes to have more collagen in them, but this is a type of spindle cell melanoma. So desmoplastic melanoma does have spindle cells in it. So the main thing is, how do you distinguish from a non-melanocytic spindle cell process? So they're going to be needing to do some of the immunoperoxidase stains, and we like SOX10 in our laboratory. S100 protein reportedly positive up to about 95% of cases, but not 100% of cases. And I've seen a couple of these over the years be S100 protein weakly positive or even negative. So beware of that. These often don't have pigmentation in them. If you see lymphoplasmacytic aggregates, that's helpful. But you can sometimes see that in neurofibromas and in other lesions too. So that's not a criterion for diagnosis. It's a helpful clue. And these also will involve nerves pretty commonly. So just remember that entity. Tough to diagnose clinically and histologically. Just remember, when you got a spindle cell lesion, always think of desmoplastic melanoma. Okay, different category here. We've got a enucleation biopsy. So this isn't your typical shave or punch or excisional biopsy. They probably had some kind of a cystic lesion. They maybe thought it was a cyst. They did a little incision on the top of it, took their scissors or something and just kind of shelled it out. And whenever something like that does shell out, that favors a benign process. So that would favor benign. And it's usually going to be a neoplasm of some sort. So here we see this, what almost looks kind of like a cystic lesion. There's this bland appearing material out on the periphery that's got this sort of fibromucinous type stroma. You've got this central area here. So we're going to go to higher magnification, see what that lining is. So we all know if it's really an epithelial line cyst, we want to see what the lining of the epithelium is. And that's lining the cyst. That's how we name the cyst. But here we don't really have an epithelial lining. We have these very delicate areas here where there's really not very many cells at all. They might even be compressed fibroblasts. And then you've got this somewhat fibrotic and mucinous stroma on the periphery. And there's really nothing in the space, maybe a little bit of a bluish gray material. There's maybe a little bit of inflammation in the periphery. So I don't know if anybody has any idea what this lesion might be. Yes, this is a ganglion, or it's a lesion that's in the bursal area. So let's say this came from, say, somebody's elbow or knee. It might be a bursal cyst. So that's really what these lesions are. They're related to the joint space. And so these little fibroblast-like cells here, the mucin and whatnot, that's really what you see in a ganglion or in a bursal type cyst. And we see the same sort of thing in a so-called digital mucus cyst. That's not really a cyst. It's really basically just an area where the fibroblasts, the perichondrial fibroblasts that make the joint fluid proliferate. They form a nodule. That lining kind of gets formed on there that you see with the here. And that's what you see if you were to do a shave biopsy of a digital mucus cyst. So it's not really a cyst. It's the same process. And there usually is, it's not really like it's a cystic lesion that's communicating with the joint space. It's really that you get like a bone spur. Those cells get proliferative. They make mucin. They get a little papule. They cause degeneration of the nail. And if you get it in the area like associated with a tendon, you get the same kind of process here. So that's a ganglion. Pretty straightforward. Nothing to be too concerned about. Just make sure that you know what these things look like and they're totally benign processes. And so these things do sometimes have some kind of contiguity with the joint space. So if you're going to go in and cut these out or whatever, not a bad idea maybe to do an X-ray or something first, like these guys did here, just to see if there is some contiguity. Because if it does communicate down with a tendon or whatever, you don't want to get into causing a tendinitis or maybe even some, maybe a osteo or something if you're doing it in your practice. So just be careful a little bit about that. So the differential diagnosis includes some of these other entities, fibromatoses, neurofibroma, et cetera. This was a pretty straightforward process, and you could theoretically encounter one of those on the board also, possibly. Okay, shave biopsy, or even maybe a deep saucerization biopsy. What part of the body? Well, it doesn't look like a typical normal epithelium. It's kind of got a pallor to it up here, and it's got a little bit of a cornified layer. Yeah, good. So somebody said mucous membrane. So it's helpful to decide where you're located, because there are certain diseases that sort of like those areas, and then things that, when dermatologists encounter a mucous membrane, there's probably only about 10 things we think about. We may think about a few benign neoplasms. We may think about some inflammatory processes, blistering diseases, maybe lichen planus, Candidiasis, those kind of things, psoriasis or something, geographic tongue. But there's not 1,000 things that we see in the mucous membrane. So it does limit your diagnosis right away. So it's helpful to kind of ask yourself, where are you located? So in the mucous membrane, so I've got this well circumscribed area here, and as we go to higher magnification, it's got these dilated blood vessels, some inflammation here. And then if you look in the center over here, it's got this, again, bluish gray material with these blood vessels that have formed with some granulation tissue. So what do we know that occurs in the mucous membrane? It occurs like a little translucent papule. You biopsy it, and it looks like this. Yeah, a mucocele. And basically, this is really more kind of a ruptured mucocele. If you see a really classic mucocele, you'll actually see the minor salivary gland duct that's filled with the mucin, because basically what happens is the duct gets plugged up, usually because of some sort of trauma. Maybe somebody bites their lip, they sever a little minor salivary gland duct. It gets, when it's trying to reform and canalize, gets plugged up, and then it fills up with the mucin, ruptures, and then you get something that looks like this. But if you ever see a real classic mucocele, you can actually see the lining of the minor salivary gland duct there. Here you don't see it. So this is, we call it a mucocele, but it's really a ruptured mucocele with granulation tissue and changes that almost look a little bit like a pyogenic granuloma. And that's actually fairly characteristic of these lesions. So here you get the minor salivary gland underneath it. So that kind of gives you a clue to what you're dealing with. And this is what they look like. And when you biopsy these, that's what it looks like under the microscope. So you'll see that inflammation, the granulation tissue, and it's a totally benign process. Sometimes you take the biopsy and that's curative. It just kind of goes away after that. Usually there's association of trauma. And you don't really have to do anything to these. Sometimes people will kind of develop these and they bite them themselves and sort of pops and it goes away and then it heals and never comes back. So anyway, it's just beware of this as well. Totally benign process, and that would be more kind of a ruptured mucocele as opposed to the one where you actually see the little salivary duct. Okay, here we've got a punch biopsy, so a different process, and you see it got this kind of superficial and deep, almost kind of wedge-shaped process going down into the subcutaneous fat here. A lot of these cells are going to be lymphocytes, and these other cells are really pale. So this, at low power, looks like it could be an inflammatory process. And as we go to higher magnification, you can see that indeed these are pale staining histiocytes here. Okay. So when we see histiocytes predominating, we think of granulomatous inflammation. And, obviously we've talked about multiple different patterns of granulomatous inflammation that we see under the microscope. So sarcoidal, foreign body, tuberculoid, palisaded, suppurative granulomatous. So those are the main patterns of granulomatous inflammation that we see. And so when we look here, we don't see, it's not sarcoidal. It may be suppurative. We'll go to higher magnification and see that in a minute. But it kind of looks like it's kind of more of a diffuse pattern here. And it's not tuberculoid, but it's certainly not palisaded. So this would maybe possibly be more in the suppurative granulomatous category. And we go to higher magnification. We've got some, lymphocytes in here, mostly histiocytes. And now we see these clear staining areas here. So that's helpful in this case. So, again, maybe it's foreign body granulomatous dermatitis as opposed to suppurative. Okay, and so here, higher magnification, we see these clear staining areas with these histiocytes here, maybe some plasma cells admixed in here. And let's go to the highest magnification. Now we have the diagnosis looking us right in the face here. So yes, leishmaniasis. So, and notice this has the classic pattern of the so-called marquee sign. We like to call it the Ferris wheel sign down here in Texas because it looks like the Texas Star Ferris wheel. And these are the little promastigotes sitting at the periphery of these histiocytes. And these are more classically seen, these little marquee signs in the New World leishmaniasis, as opposed to the Old World type. Now, you can see it in both, but generally when you see the Old World type, you see the histiocytes that are just kind of filled diffusely with the organisms, as opposed to the New World type where they tend to cluster around the periphery. That's not 100%, but if you see it, it favors that. And for a lot of people that may have been taught in the residency to call it leishmaniasis, well, Leishman was a Scot. And there's a famous professional golfer, Mark Leishman, that plays on the professional golf tour. And if you called him Mark Leishman, he wouldn't like that. So L-E-I in Scottish, you pronounce the E first. If this were German, you pronounce the I first. So it's leishmaniasis, not leishmaniasis. And these are some examples of the clinical manifestations. So there are other entities that can give you intrahistiocytic parasitization of histiocytes. So this is one, classic one. Donovaniasis, another one, Granuloma inguinale. So there's about 5 of them that you guys should know. The Klebsiella can do it, rhinoscleroma. So let's make sure you know those intracellular, histo and some of these, they all can kind of look a little bit alike. None of them give you this pattern though. You see that classic marquee sign, it's leishmaniasis. So just remember that. And then these are just some clinical manifestations. So I would recommend knowing a little bit about this, the organisms that cause the Old World versus the New World type, the sandflies, the phlebotomist versus the Lutzomyia, which are the 2 different types of sandflies that carry this. And, we see patients that have been in the Middle East, military, maybe they've been fighting in Afghanistan or Iraq, and they come back to the United States and they bring it with them. And then we see people that have been in Mexico or South and Central America, or even in Texas, where now it's endemic here. We see a number of cases every year that are just localized. People have never left the area. So anyway, just remember the pattern, pretty classic. And you get that when you see that marquee sign or the the Ferris wheel sign, think of leishmania. Okay, we've got a shave biopsy. Looks like a dome-shaped papule. Kind of looks like a skin tag, but it's got something else going on here down at the bottom that looks a little bit weird. So we got a little sebaceous lobule here. We've maybe got an occasional little epidermal hyperplasia, a little papillomatosis, and then we're going to look at these little areas down here. We've got these ducts. We've got a little bit of a loose stroma here, some fat, and then we've got these glands here. Okay, so Accessory nipple, somebody says, but there's one thing in here that you don't see in a nipple. So what are we looking at in this field that's not present in a nipple? And that is glandular epithelium. So in an accessory nipple, you see ducts, you see the sebaceous hyperplasia, you can see those. You can get the smooth muscle bundles, which we're not really seeing here, but you don't get this glandular epithelium. So in that situation, so you're right, it's related to the breast, but here we've actually got accessory breast tissue itself. So it's not just accessory nipple, it's breast. So where might this come up in dermatology? Well, let's say somebody comes in like this and they've got this expanding dermal area, and the clinical differential is probably a lipoma. So you take an incisional biopsy, you try to get out all the fat and everything, and you send it in, and guess what? It shows breast tissue. So the tail of the breast in women, not uncommonly, kind of extends up into the axilla. So you'll see this on occasion. Somebody will take a biopsy of something. Maybe they think it's a lipoma, they think it's some kind of cyst or something, send it in, and it's an accessory breast. So it's also usually occurs along the embryologic milk lines, and the axilla is the most common location. So the only thing to remember is that if you see breast tissue, glandular tissue, it's breast. If you don't have that and it's got the other features, it's a nipple. And, you know, it's of more than just interest histologically, because patients that have accessory nipples and they have accessory breast tissue can sometimes develop Paget's disease or breast cancer in those areas. And we occasionally will see mammary Paget's disease, or what's kind of extramammary Paget's disease, developing in an accessory nipple or accessory breast tissue in either a man or a woman. And that can behave just like Paget's disease on the breast of a woman if it develops in the milk line. Or if they get breast cancer in the accessory breast, it can behave like a breast cancer. So it's relatively rare, but occasionally dermatologists do encounter this. And we just had a case about a month ago of a man that had an accessory breast, he developed Paget's disease in his accessory nipple, and then developed metastatic disease from that. So it can happen in dermatology. So again, occasionally dermatology will intersect with general pathology. Unfortunately, the outcome is often not great because we don't tend to think of general pathology stuff as much. But just remember that basically you can get accessory breast tissue in addition to accessory nipples. Okay, another enucleation biopsy in this case. Okay, so once again, probably felt like a cyst. Again, anytime something feels like a cyst, you should have some respect for that, because once again, there are lots of things that can present in the skin that we think are cysts. We cut into them, and they're not. They can be adnexal tumors, they can be metastatic lesions, they can be things like neural lesions, muscle lesions, all sorts of stuff. It can look like a cyst, or they can just be a regular cyst, but they don't have to be. So here we've once again got an enucleation biopsy. You can see that it looks very well circumscribed. You can just basically draw a line around it here. We'll go to higher magnification, and once again, it's a spindle cell lesion. Okay, and it's got this little cleft in here, and that might actually be truly lined by something. Here at this power, we can see these fascicles of cells that are interweaving. The cytoplasm is pink, and these cells look kind of like little cigars right here. They don't have that lazy S appearance like we see with a neural lesion, for example. And the stroma is not loose and myxoid. It's more eosinophilic. And there's some little small vacuoles interspersed in here as well. So when we see that, what do we think about? We think about muscle. Good. And so a couple people said leiomyoma, and somebody put pilar leiomyoma. Now, what's not so great about a piloleiomyoma? What's the difference? So there's three main types of leiomyomas in the skin. There's the pilar type, which come from the rector pili muscles. There's the scrotal type, or the erectile type, which comes from scrotal tissue or erectile tissue in the labia, for example. and you know, the dartos muscle. And then you've got another type, this type, which comes from blood vessels, the angioleiomyoma type. Good. And this type usually looks like a small, round, nodular lesion. Those others are more plaque-like lesions. They're more diffuse. And so when you look at them under the microscope, they don't usually have this solid component like this, where you've even got some areas where there's like a blood vessel. Over here, you've got a blood vessel where this kind of arose off the side of it here. So this is an angioleiomyoma. Okay, so good. So good, you got the muscle part, that's good. And if it looks like a round nodule that shells out, think about angioleiomyoma, okay? And these can look like this, or they can just look like a subcutaneous nodule. And they can come in as a cyst or something like that. And these can be painful. They're in our painful Bingle, England, Angel, whatever you use as your mnemonic device there. So just remember this, and just remember the morphology of smooth muscle histologically. And if you wanted to stain it, obviously you could do just smooth muscle actin, or Desmond will stain these many times. So just remember what this looks like histologically. The one item in the differential diagnosis is obviously a leiomyosarcoma, usually larger with more atypia, et cetera. We'll talk about that a little bit later on. Okay, classic board question. So you're going to get this. Somewhere on the board exam, you're going to get this question. So it's nice to know. Once you know for sure you're going to be tested on it, you may as well just go ahead and make sure you know it like the back of your hand. So presumably in your third years, this should be review. Second and first years, make sure you understand this concept very, very well. So we've got a shave biopsy here. And we've got an intraepidermal process going on, an intraepidermal vesicular process. So we know there are three main ways of getting intraepidermal blisters. We can get spongiosis, we can get ballooning degeneration, and we can get acantholysis. Okay, so we're going to look at higher magnification. And which of those are we getting here? The cells are falling apart. So this is acantholysis. Good. Now to look at acantholysis, we ask ourselves, is there anything about that that's helpful to us? What can we do to kind of be more specific with acantholysis? So is there acantholysis plus dyskeratosis, which is seen more commonly in things like Derrier's disease and Hailey-Hailey disease sometimes, and then Grover's disease, those conditions, the conditions that give you the acantholytic dyskeratosis. If the acantholysis is present, is it just just above the basal cell layer? Is it just beneath the cornified layer, maybe in the granular cell layer? Or is it diffuse, going throughout the entire epidermis? What's the extent of the acantholysis? And what's the extent of it horizontally? Is it tiny foci, like Grover's, or more diffuse, like here? Those are all things that help us. So we look here, and there's some dyskeratosis. And the acantholysis is not confined to just the basal cell layer. It goes all the way through, all the way throughout the epidermis. There's a lot of crusting. There's some purulence. So you can imagine clinically what this would have looked like. And also notice that it's diffuse. It's going to basically most of the biopsy. Low power goes side to side. So it's not just a tiny focal acantholytic process. There is some dyskeratosis as well. So we've got this diffuse, so-called dilapidated brick wall. And once you say dilapidated brick wall, you can't not think of the diagnosis, right? Of course, Hailey-Hailey disease. And that's actually what this is. This one's got more dyskeratosis than the average bear, if you will. So most Hailey-Hailey doesn't have this much dyskeratosis. So this is kind of an interesting pattern. If I just saw this alone without any further information, I would probably favor Derrier's personally, just under the microscope. But if they say, well, it looked like this, it looked like wet tissue paper in an area that's very macerated under the arm, on the neck, the groin, well then, I don't care what it looks like histologically, that's just basically Hailey-Hailey with more acantholysis. But if I was just looking at this histologically alone, because it's got so much dyskeratosis, I would favor Derrier's in that situation. So Hailey-Hailey, it's so easy to get that they might give you a second order question. So whenever it's easy to diagnose histologically and or clinically, they may start asking questions about treatment. So how do you treat this? Well, it's not easy to treat. You want to make sure you get rid of any of the other things that can make it worse, like Candida or staph infection or herpes infection. And you need to know what the mutation is. You might even want to know what that mutation does, what that gene actually does. I mean, is it associated with calcium transport? Is it what, so make sure you know a little bit about that. Whenever there's a gene, you need to know about this, but you definitely need to know the histologic reaction pattern of acantholysis and acantholytic dyskeratosis. So that is classic. You've got to know that. Okay. Now we go to something more banal and something easier, but the board likes to show some of these easy things too, to intersperse with the tough stuff. They don't want everybody to flunk. And so, in fact, hardly anybody flunks the exam. You have to kind of be comatose if you flunk the exam. It's not like other exams where they have 30, 40% passage rates. This has a 90-some-odd% passage rate. So if you know what you're doing and study, you're going to pass, but you can't just slough it off and forget about it. So here we've got a shaved biopsy of a dome-shaped papule, and we've got this area of, hope you guys know what that is. Okay, that's cartilage. And then above it, we've got what looks almost like a little skin tag. So you can imagine what this looked like clinically. It looked like a little tag. It's got a little bit of cartilage at the bottom of it. Okay, and it's only at the bottom. And then we've got these little small miniaturized follicles here, little vellus hair follicles, a couple of baby sebaceous lobules, little tiny eccrine sweat glands, a lot of fat in this. So anybody know what this diagnosis is? Yeah, good, accessory tragus. Now, that's so easy to diagnose, and they do have pediatric dermatologists that ask like questions for the board. So they might ask you some other questions here about branchial cleft abnormalities. So, what other kinds of branchial cleft things can you get with accessory tragi, with say like thyroglossal duct cysts at midline lesions and things like that. So I would recommend boning up a little bit on that. But this is a pretty classic example of an accessory tragus. It looks like a skin tag. It's got a lot of fat in there. It's got these little miniaturized cutaneous adnexal structures. And then if you get lucky, you'll see the cartilage in it. And if you see it like this, it's pretty straightforward. So hopefully nobody had any trouble with this thing. It's a simple, easy, gimme diagnosis, but they might possibly ask you some second order questions about other kind of things that can be associated with branchial cleft abnormalities. Accessory thyroid tissue, for example, or thymus tissue. All those are some other things that you can see. Okay, shave biopsy. Here we're dealing with a neoplastic process. Notice there's this acanthosis here, and we've got these sort of pale clonal areas within the epithelium here. So it's an epithelial process. Is it benign or malignant? It's pretty well circumscribed over here, and chat boxes here, but the same kind of thing was on that side of the lesion when you looked at your slide. As you go to higher magnification, we've got these little clonal areas within the epidermis here. Okay, some overlying parakeratosis. But notice there's really not a lot of atypia of these areas. Okay, and you got these they're almost kind of like little small cuboidal basophilic cells admixed with clear staining cells within it. And there are these horn pseudocysts. Okay, but there's no atypicality. There's no mitotic figures to speak of. There's no ductal differentiation. There's a little bit of pleomorphism here, but not striking atypicality here. So one thing we sort of like to do when we're doing live sessions is we sort of like to say, well, if you're going to be writing a question for the board examination, what choices would you put down that you want to trip up your colleagues, for example? Say you're writing a question and you want to trip up your co-test takers, so you're going to get it right and they're going to miss it. So what are some things you might want to put on your your choices there. Well, you might say, hey, maybe squamous cell carcinoma in situ. Maybe this is Bowen's disease. It's a couple of atypical cells. Maybe it's squamous cell arising here. Maybe you put down hydroacanthoma simplex. Maybe people say these are poroid cells. Well, they're really not, but they're these little clones. Maybe put down other intraepidermal malignancies. Maybe put down something like Merkel cell. Maybe Langerhans cell histiocytosis. Maybe put down melanoma. So those are some other things that can involve the epidermis. But here you've got classic area of seborrheic keratosis with these little clonal areas. So yeah, somebody wrote clonal SK, and maybe what it looked like. Clinically, there's no way to tell these apart from other SKs. It's just histologically, it's an interesting finding, and it's a benign process that can simulate malignancy. So you might encounter this on the exam. It's possible, a little bit esoteric, but they might put it on here. And this has also got another name to it. It's called a Borst-Yattesen keratosis, totally benign lesion. And it simulates some of the other intraepidermal malignancies on occasion. Sometimes it can be a little more atypical, kind of look a little bit like Bowen's disease. So just make sure that you don't overcall it that. Maybe it could look like a condyloma. I probably wouldn't think of that too much here, but it's just another example of an interesting lesion that's got an unusual histologic finding that can sometimes simulate a malignancy. Okay. We've got a punch biopsy. It's got a verrucous epithelial hyperplasia here, and it's got a very dense inflammatory infiltrate in it. And off to the side, it's got an ulcer associated with it. So this is probably not something you're going to get on the exam, something like this. And it's sometimes worth at least having an unknown that's got something unusual that you have to do something different than the typical finding. So if you're just looking at this, the diagnosis is probably like an irritated SK or a wart with a lot of inflammation in it. But why all the inflammation? There's something else going on there. And maybe there's two diseases going on. It's hard to tell what part of the body we're on. We don't have a lot of follicles here. So maybe we're near mucous membrane. And maybe the guy does have a wart. Then he's got this inflammation, and they got this ulcer over here, and it's got very, very dense inflammatory infiltrate. And then you start looking and you say, well, whenever there's an ulcer, we say, well, why is it ulcerated? Is it just a trauma? Is there some underlying process that caused ischemic necrosis and it ulcerated? Is there some kind of chemical applied to the area to cause an ulceration? Is it an ulcerating disease like pemphigus or Hailey-Hailey or something like that? Or maybe there's some other reason for the ulcer. And if you look here, hopefully you did, you can see some pathognomonic findings of why it's ulcerated. Yes, this is herpes virus infection. And it's probably herpes virus infection, herpes virus type 2, in a person that's also got condyloma. So this person isn't engaging in safe sexual practices. Might even be an HIV positive individual. So if you see something like this, obviously you would want to, figure out why the guy's got to venereal disease at one point. Maybe ask, did the person have HIV infection? And it might be a clue to the diagnosis. Here you can see a multinucleated giant cell over here, and then you've got these cells that's got the classic herpetic viral cytopathic effect. So it's kind of subtle. You had to look for this. I don't know if everybody saw it, but this is pretty characteristic. Sometimes herpes, you can get like a very, very dense inflammatory infiltrate. You can get vasculitis, you can get lichenoid inflammation, you can get granulomatous inflammation, you can get just very dense diffuse inflammation like this in herpes. And if you don't see the viral cytopathic effect, you can miss a diagnosis. So here, this pretty obvious clinical, but this guy actually had two different conditions going on. And so just remember, you got to look carefully when there's an ulcer to see what's causing it. So here it was diagnostic, you just had to look for it. So other things that cause ulcerations are other viral infections, or Milker's nodule, parapox infections, the Coxsackie viruses, those can give ulcerations. So just think about whenever you get ulcers that viruses can cause that, and look to see the classic histologic findings, look for ballooning degeneration and the acantholytic cells. Okay, here we got a pretty large excisional biopsy. Pretty easy also, so hopefully this wasn't much of a challenge to you. So it's got a, you can't see the size of it, but pretty big, but it was excision. And overall, it was relatively symmetrical, well circumscribed given the relatively large size of the lesion. But it's another spindle cell proliferation, but it's also got an epithelial component to it. So here we see the cells are more angulated and jagged in shape. There's some dilated blood vessels. There's some inflammation. We've got this basaloid proliferation at the dermoepidermal junction. So here we've also got these thick keloidal collagen bundles at the periphery. So the diagnosis is, yes, somebody put dermatofibroma. That's exactly what this is. And there's also some of this change overlying it, which is kind of interesting. So overlying dermatofibroma, it's not at all uncommon to see basaloid follicular induction overlying it. So make sure you don't call that a basal cell. That's normal. That's not cancer. We see that pretty commonly over DFs. And this one actually had sebaceous induction also, which is relatively rare. We don't usually see sebaceous induction in addition to follicular. So usually it kind of looks more like a basal cell overlying it. If you get a shaved biopsy, you may only get the basaloid proliferation, and you may call it a basal cell. And they go back and re-excise it into dermatofibroma. And that's not a fatal misdiagnosis, but it's a diagnosis that happens because the dermatologist misguides the dermatopathologist, doesn't take a sample that gets deep enough. So just remember that that can happen as a sampling error. So dermatofibroma with basaloid induction. Now, there are a few situations where you can actually see eruptive DFs, lupus, classic one that you can see, a few other conditions, but lupus is probably the most common one in the literature. So that's possibly could end up on a multiple choice question or something, just remember that. And then the immunoperoxidase staining, factor 13A positive, CD34 weakly positive, not totally negative because it'll hit the blood vessels there. Usually, DFs don't look like DFSP. That's in the literature. Everybody says it. It's like a reaction pattern. Everybody, or that's just a reflex arc. It almost never looks like a dermatofibroma. Usually, neurofibroma looks closer to it than a dermatofibroma. So it's not usually difficult at all to distinguish between the two. Okay, here we've got a punch biopsy of something in the dermis here. Low magnification. No epidermal involvement, mostly the lower dermis. And the cells are blue and they're diffuse and they punched into the middle of this thing. So we don't know anything about the breadth, the symmetry, the circumscription. Is it an inflammatory or neoplastic process? Well, if it's inflammatory, it's got a lot of dark, deep blue cells and they're too big for classic lymphocytes. So even at low power, we say something ain't right about this. This doesn't look good. And it's also got down, it even goes all the way to the fat. And we're going to higher magnification. Again, you got these basophilic cells. These may be lymphocytes up here. They probably are, but these are not. And we're even higher magnification. And now they don't look like lymphocytes. They're not jet black. These are fuzzy purple cells. Fuzzy, blurry. They don't look crisp. And that's not because they're taken out of focus. This is what these cells look like when you look at them under the microscope. So these cells are, whenever you see that, you should think of neuroendocrine differentiation. Neuroendocrine. Now, there is a differential. You can see that with some large cell lymphomas, they can get fuzzy and more cytoplasm, but not usually this like this. And here you've got these individually necrotic cells, you've got mitotic figures, you've got some of the cells are arranged in cords and strands. So somebody put Merkel cell. So yeah, neuroendocrine could be Merkel, but what's unusual for Merkel here? Well, there's no epidermal involvement. There's no dermal, no epidermal involvement. So if it's a Merkel, it might be metastatic Merkel. Or if it's not metastatic Merkel, it might be metastatic small cell carcinoma, neuroendocrine carcinoma. And then what type of neuroendocrine? Primary Merkel? metastatic Merkel, metastatic small cell carcinoma from an internal site. So here's cytokeratin. It's giving you this paranuclear dot pattern. And the classic one we see is cytokeratin 20. Even better example of the paranuclear dot pattern here. And then there's another marker that I like even better today, INSM1, insulinoma marker, which is a nuclear marker. It stains all of these cells positive, better marker than neuron-specific enolase or chromogranin. So these are some examples of Merkel cell. And if it were metastatic lung small cell, what's the stain we like to do for that? Okay, I'm sure some people know the answer to that. Yeah, TTF1, thyroid transcription factor 1. So if you see that, it favors a small cell that's metastasis. Now, it doesn't mean that it is. I've seen some primary Merkels with that also. But if it's positive for that and negative for the others, or positive for CK and then the paranuclear dot pattern and it's got that, favors that. So you always work the patient up. It's not 100%, but it favors it. And so would we always get a TTF1? Well, never always, but yeah, we usually do. Most of the time, we usually do get that. So it's helpful when it's positive, especially in a pattern like this. Okay, here we've got a punch biopsy, diffuse involvement, spindle cell involvement once again, and we've got the same type of cells we had before with the smooth muscle cells, but this one was a little bit different, diffuse, because it also had some atypical cells admixed in here. So these cells are hyperchromatic, and there were some mitotic figures in here, and there's a little bit of atypicality. So this one was, we only had a punch, but this was more diffuse, more poorly circumscribed. It's got mitotic figures in it. So diagnosis in this case probably didn't look like that. So this is a low-grade cutaneous leiomyosarcoma. Some people also even call these things atypical leiomyomas. And the good news about leiomyosarcoma when it occurs in the skin is that it's got a much, much, much better prognosis than a leiomyosarcoma that occurs, say, in the uterus, that they spread throughout the body. These lesions in the skin, they almost behave, they behave better than dermatofibrous protuberans. Just cut them out, get them out, they do fine. So they rarely metastasize. Now, if they've got a very marked number of mitotic figures, anaplastic, et cetera, maybe you think about that. But when it looks like this, there's got a few atypical cells and whatnot, you don't really think, you basically just treat it almost like a squamous cell carcinoma, or like a primary melanoma, and you just cut it out, and the patients really do very well. Okay, here we've got a punch biopsy. It's got all this pseudoepitheliomatous hyperplasia. It's got a dense infiltrate of lymphocytes in here as well. It's got marked overlying epidermal hyperkeratosis. So somebody's been rubbing the heck out of this. So we've got pseudoepitheliomatous hyperplasia with a dense infiltrate of lymphocytes. And these are regular tongues of epithelium here. We've also got a lot of these thick dilated blood vessels that we see on the lower leg. So stasis change with pseudoepitheliomatous hyperplasia with a dense band-like infiltrate of lymphocytes around the base of some of these. What diagnosis do you think about? And here we've got wedge-shaped hypergranulosis. We've got some irregular sort of sawtooth epidermal rete. Yeah, this is hypertrophic lichen planus. Hypertrophic LP. This field is really good for it right here. It just shows you what these things can look like. And sometimes they only have a lesion or two like this, and it can look like a squamous cell carcinoma. Somebody does a shave, it's called squamous cell or keratoacanthoma, and then they get an excision, and then it kebnerizes. It doesn't go away. So the treatment of choice of hypertrophic lichen planus is not excision, because lichen planus kebnerizes. So you just want to make sure that you get a good biopsy of this. You know the differential, you know the way that it can develop. So basically, it's lichen planus with marked pseudoepitheliomatous hyperplasia, usually related to rubbing and scratching. And it's usually the most common location is on the lower legs. So just remember that, and it can simulate cancer. So we've seen a lot of cases over the years where we get that phenomenon. Okay, punch biopsy. Once again, we don't get a lot of follicular structures here. So maybe it's on a mucous membrane once again. And we've got this abnormal cornified layer. We've got psoriasiform hyperplasia. We've got an infiltrative lymphocytes. And then we've got this change up here. So hopefully you guys recognize this. This is one where you don't need a special stain. This is Candidiasis. Good. And notice the organisms, they're drilling down. They're almost going, they're like drilling for oil here. They're going down from the cornified layer, which often in mucous membranes, there may not even be a cornified layer, and they're trying to get into the epithelium. So dermatophytosis likes to go side to side, horizontal, sandwich side. This thing likes to zoom down into your skin, and it's got, this one even had some yeast here as well. And so these are pseudohyphae, and you'll get pustules with this process. Sometimes you can get verrucous candidiasis, you get epithelial hyperplasia, it's like a verrucous hyperplasia with LP. You can get verrucous hyperplasia with candidiasis. And it can simulate a cancer here also. So the way to go if you get that situation is you treat the candida, see what's left over, then take another biopsy at the end of the day. Make sure that it's not a cancer that has got candida on top of it, but you can basically get a lot of epithelial hyperplasia and candidiasis. Now, erythrasma are teensy tiny little dots with fine filamentous organisms there. If you see the little tiny dots with thin bacteria that you see, they don't look anything like candida, and they may be going down from the cornified layer also. They can drill down this way also, but they never really make it into the epithelium, and the morphology is much different. You don't see any yeast with that. So these are tiny filamentous bacteria with erythrasma. Okay, so that's it. You guys did a good job. Thank you for participating in the chat room. We'll have another talk on Monday. We'll submit everything later today, and we'll give you another section to look at next week. We'll continue the unknowns, and hopefully you guys are enjoying these. So keep quizzing yourself, and you'll get good, and you'll pass the boards with flying colors. Thanks a lot, and have a great weekend.